Chapter 30, Lower Respiratory Tract Infections. Let's start with acute bronchitis. This is a self-limiting inflammation of the bronchi, most commonly caused by viruses. Other triggers include pollution, chemical inhalation, smoking, chronic sinusitis, and asthma, and has many common symptoms such as cough, clear purulent sputum, headache, fever, malaise, dyspnea, and chest pain. Next would be pertussis, or Bordetella pertussis. This is a gram-negative bacteria that attaches to the cilia and releases toxins, resulting in inflammation. It's highly contagious, with increased incidence within the United States. These patients are going to be on strict droplet precautions, as well as immunity from DPT decreases over time. The CDC recommends a one-time vaccine for adolescents over 11 years old and adults who did not get the Tdap. This could also be called whooping cough. Next would be pneumonia. There are many different classifications of pneumonia, and it could be classified according to the causative organism, the characteristics of disease, or the radiographic appearance. The most effective classification is the community-acquired or hospital-acquired, and these helps identify the most likely organism and antimicrobial therapy. In the case of community-acquired pneumonia, this is an acute infection in patients who have not been hospitalized or resided in a long-term care facility within 14 days of the onset of symptoms. It can be treated at home or hospitalized depending on the patient's age, vital signs, mental status, comorbidities, and condition. In the case of hospital-acquired pneumonia or nosocomial pneumonia, it occurs 48 hours or longer after hospitalization and is not present at the time of admission. Another variant would be ventilator-associated pneumonia, and this occurs more than 48 hours after endotracheal intubation. For our types of pneumonia, viral is the most common. It may be mild or life-threatening. Same thing with bacterial, which may require hospitalization. Other more rare forms are mycoplasma, atypical, also aspiration, necrotizing, and opportunistic. Aspiration pneumonia especially is a major killer. Another may be PJP, or pneumocystis jirovecii pneumonia, and this is a fungal infection that's most common among HIV patients. It has a slow onset and subtle symptoms, including fever, tachycardia, tachypnea, dyspnea, a non-productive cough, and hypoxemia. Chest x-rays would show a diffuse bilateral infiltrates to massive consolidation. It can be life-threatening, leading to respiratory failure, and even spread to other organs. Another form may be the cytomegalovirus pneumonia. It is often asymptomatic and mild, but can vary to severe disease in those with an impaired immune system, especially in the case of HIV or previous organ transplant. It's the most important and life-threatening complications after hematopoietic stem cell transplantation. And the treatment is antiviral medication and high doses of immunoglobulin. The most common manifestations include a cough with productive or non-productive, green, yellow, or rust-colored sputum, fever and chills, dyspnea and tachypnea, and pleuritic chest pain. For older or debilitated patients, could also include confusion or a stupor along with hypothermia. Other major complications of pneumonia include atelectasis, pleurisy, pleural effusion, bacteremia, pneumothorax, acute respiratory failure, sepsis or septic shock, a lung abscess, or empyema. For our diagnostic studies would include a history and physical examination, along with a chest x-ray, thoracentesis, and or bronchoscopy. Keep in mind, this comes up a lot in ATI and NCLEX. Anytime a patient has a bronchoscopy, echo, anything that goes down the throat, that patient is in PO until the gag reflex returns. Because again, that major danger, that major killer of aspiration pneumonia. Also be monitoring it with pulse oximetry, ABGs, a sputum, grand stain, culture, and sensitivity to identify the pathogen to more effectively prescribe antibiotics. Also blood cultures and a CBC with differential. Also, pneumococcal vaccines for those age 65 and over could go a long way in helping to prevent pneumonia in the first place, especially that streptococcus pneumonia. With prompt treatment with antibiotics, we want our response generally to occur within 48 to 72 hours, especially in the case of decreased temperature improve breathing, and decrease the chest discomfort. We're going to want to repeat that chest x-ray in 6 to 8 weeks as well. Also, keep in mind providing the adequate fluid and nutrition. We're going to provide small, frequent meals to keep their weight up, keep their strength up as they deal with this infection. To prevent aspiration pneumonia, we want to elevate that head of the bed 30 degrees and have it sit up for all meals. This is also true in the case of feeding tubes and peg tubes. We want to assist the patient with eating, drinking, and taking meds as needed, carefully assessing the gag reflex and monitoring for reflux and gastric residuals in NG tubes. Also, things like early mobilization, coughing and deep breathing, incentive spirometry, and twice daily oral hygiene. And keep in mind, these aspiration pneumonia is most common in post-stroke and altered mental status patients, so we need to be especially vigilant in these cases. Medical asepsis and infection control, including hand hygiene, sterile techniques with tracheal suction, careful handling of respiratory equipment, and avoiding inappropriate antibiotic use can also go a long way in improving the prognosis. Next, let's talk tuberculosis. Tuberculosis, or TB, is an infectious disease caused by Mycobacterium tuberculosis. The lungs are the most common site of infection, and up to 1/3 of the world's population are latent carriers of the bacteria. Some studies will say the prevalence in the United States is decreasing, while you will see other figures saying that we are about to be increasing or currently increasing. And the most definitive diagnosis is a sputum culture, though chest x-rays will be ordered to identify any scarring or indication that way as well. The biggest danger with tuberculosis is multi-drug resistant tuberculosis. And this would be a bacteria that's resistant to two of the most potent first-line anti-TB drugs, isoniazid and rifampin. In cases of extensively drug-resistant tuberculosis, this could be resistant to any fluoroquinolone, plus any injectable antibiotic. Keep in mind that isoniazid especially is severely hepatotoxic. This is a very commonly given tuberculosis drug, especially in the cases of latent tuberculosis. It's usually a combination of isoniazid along with other medications. And when they say severely hepatotoxic, this is a drug that the patient should never drink on. Tuberculosis is one of our three pathogens requiring airborne precautions, the other two being varicella and measles. There is a good acronym to help remember which three pathogens are, and that is MTV, measles, tuberculosis, and varicella. The danger of these pathogens is that they don't require a droplet or anything to ride on. Just the exhaled breath carries enough of a viral or bacterial load to infect another. And once inhaled, they lodge within the bronchioles of the alveoli and begin to multiply. Only 5 to 10% of people with dormant tuberculosis will develop the active TB, and this may take months or years later to appear. Another classification system deals with the presentation. In the case of primary TB infection, the bacteria are inhaled, the inflammatory response occurs, and if adequate immune response, infection does not progress to disease. In the case of active TB and primary TB, that active disease will develop within 2 years of the infection. Whereas in the case of reactivation tuberculosis, post-primary, the disease occurs greater than 2 years after an infection. Another is latent tuberculosis, meaning the patient has tuberculosis bacteria within them, but the immune system is fighting it off, keeping it in check. That's what we're seeing with those two-step TB tests I'm sure you get. Infected but positive skin test does not mean that they have active tuberculosis. These patients are often asymptomatic and non-infectious, though they do have the danger of developing active TB later, especially in the case of things like immunosuppression, diabetes, normal aging, pregnancy, stress, or chronic disease that also further inhibits that immune system. It means it's no longer able to keep that bacteria within check. In the case of pulmonary TB, it can take up 2 to 3 weeks to develop symptoms, with a characteristic dry cough that becomes productive. Other symptoms include fatigue, malaise, anorexia, weight loss, low-grade fever, and night sweats. If you ever see night sweats on NCLEX or ATI, that is one of those hallmark things. You really need to be thinking on TB there, because that's probably what they're cueing you into. Also late dyspnea and even hemoptysis. As we said, a sputum culture is the only definitive diagnosis for tuberculosis, though other indications may be that magnitude test that you may have already got, that it's screening for TB with a purified protein derivative and can identify if the patient has antibodies towards tuberculosis. We want to inspect that site for induration or that wheal, that swelling, 48 to 72 hours. That induration should be palpable, raised, hardened, or swollen area. In the case of a positive result, it is very, very noticeable. I used to teach intro to nursing a few years back, and every now and then I'd get a student come up to me with their TB test and come real close and ask me to take a look at it. And yeah, it's just slightly bruised. That's normal for part of the injection. I'm flattered you thought you had tuberculosis and you came up real close and whispered to me so I could take a look. But when it is swollen with a positive result, it is very, very noticeable. And there are going to be different standards for different parts of the population. For the general population, a result of 15 millimeters or greater in duration. In the case of RNs who are at a higher risk of exposure, ours is going to be 10 millimeters or larger would indicate a positive result. And in the case of those immunocompromised, such as HIV organ transplants, a result of 5 millimeters or greater indicates a positive result. Because again, they don't have the immune system to react with that. A false positive and false negative reactions may also occur with this. For diagnostic studies, a chest x-ray. They cannot make a diagnosis solely on a chest x-ray, but they can see the scarring where the body is walling off and managing the tuberculosis. They may appear normal in a patient with tuberculosis, with suggested findings such as upper lobe infiltrates, cavity infiltrates, lymph node involvement, and pleural and/or pericardial infusion. That TB cultured is the gold standard. You're going to need 3 consecutive sputum samples at 8 to 12-hour intervals, and at least a specimen in early morning. The idea is, how can we definitively prove that this patient doesn't have tuberculosis before we take them off of airway precautions? They need 3 consecutive negative sputum samples. That initial test is sustained sputum smear. The next would be for that definitive diagnosis. It's going to be that mycobacterial growth that can take up to 6 weeks and can also collect samples from other suspected TB sites. Most latent tuberculosis infections are treated in the outpatient setting. They're considered infectious for the first 2 weeks after starting treatment if the sputum is positive. And remember, this is a case where we're going to restrict visitors and limit public exposure to the bacteria. Also, remember about strict hand hygiene and oral hygiene. We're also going to include an aggressive drug therapy to treat the active disease and prevent any drug resistance as well. While not given in this country for tuberculosis, there is a vaccine, the Bacille Calmette-Guerin vaccine. I hope French was always my weakness. But anyway, not given in for TB in the US, and it is a live attenuated strain of the virus. It's given to infants in parts of the world with high prevalence of tuberculosis. In the United States, it's not recommended due to the low risk of infection, though that BCG vaccine can result in a positive test. So anyone born outside of the country that received this vaccine will always come back positive on those Manitou 2-step intradermal TB tests. We can't stress enough airborne precautions, negative pressure room, respirators. They're going to be in a single occupancy room with 6 to 12 airflow exchanges per hour. Healthcare workers are going to wear those high efficiency particulate HEPA masks, fit testing, and they're going to get an immediate medical workup, including chest x-rays, sputum smear and cultures, while they identify the appropriate drug therapy or combination of antibiotics. This is also going to be a case where we notify the public health department. We're going to teach the patient about symptoms of reoccurrence and other factors that could reactivate the tuberculosis. Also, the importance of smoking cessation, as the tuberculosis is also damaging the lungs. Moving on to lung abscesses. This is necrosis of lung tissue from aspiration of bacteria from usually a periodontal disease. Others include IV drug use, cancers, PEs, lung infarctions, tuberculosis, parasitic and fungal diseases, and sarcoidosis. Environmental lung diseases, or this is occupational inhalation of dust or chemicals. And in this case, the lung damage depends on the toxicity, the amount of duration of exposure, and the susceptibility of the individual. Here's our picture there of a coal miner. Black lung is a major, major killer of those who spend a lifetime working in coal mines. These environmental lung diseases usually manifest in 10 to 15 years, with dyspnea, cough, wheezing, and weight loss. Pulmonary function tests can be used to reduce vital capacity, and the chest x-rays to scan for that lung involvement. Also, cor pulmonale, or right-sided heart failure, due to that diffuse fibrosis and the damage caused from that contamination. Another major complication is the COPD that will develop in later stages, including acute pulmonary edema, lung cancer, mesothelioma, or tuberculosis. Next, let's talk about lung cancer. Lung cancer is the leading cause of cancer-related deaths within the United States at 28%. It's estimated that there's 234,000 new cases in 2018, with 154,000 deaths. It has a high mortality rate and unfortunately a low cure rate, though advances in treatment are improving response. The risks related to total exposure to tobacco smoke include the total number of cigarettes smoked, the age of smoking onset, depth of inhalation, the tar and nicotine content, and the use of unfiltered cigarettes. Side stream or secondhand smoke is also a health risk. Other causes of lung cancer include exposure to pollution, radiation, asbestos, or industrial agents like nickel, uranium, or formaldehyde and arsenic. Manifestations include a persistent cough with sputum being the most common, along with hemoptysis, dyspnea, wheezing, and chest pain. Screening for lung cancer should occur annually in adults aged 55 to 77 with a history of smoking. This would be a 30-pack year history, current smoker, or quit less than 15 years ago. Next, let's talk chest trauma and thoracic injuries. Traumatic injuries to the chest contribute to many traumatic deaths. And these range of injuries such as simple rib fractures to cardiorespiratory arrest. The mechanism of injury could range from blunt, such as shearing and compression injuries of chest structures, and external appearance may be minor, but they could have severe internal organ damage underneath. Also, penetrating damage. This would be a foreign object impaling or passing through the body tissues, creating an open wound that then allows air into the pleural cavity but outside of the lungs, impairing respirations. As we can see here in our figure on the right, we have a damage to that pleural area, and it's now allowing air to enter the pleural space but outside of the lungs. And that lung is now unable to make the pressure changes to inflate itself and breathe. And we've got to be able to remove that air and seal that sucking chest wound to allow that lung to reinflate. Other signs to assess for within respiratory distress include dyspnea, cough with or without hemoptysis, cyanosis, tracheal deviation, because as that one lung is unable to expand, the other is still expanding, and it can actually pull that trachea off to the side. You've also got that up there in that diagram that may be a little more, because as that only one lung is expanding, it's actually pulling that trachea over. Other things would be decreased breath sounds, obviously, on that side, a decreased O2 saturation, and frothy secretions. Another fun one is a flail chest. In this case, you have 3 or more consecutive rib fractures in 2 or more places. And what is happening is actually an entire section of that chest wall is broken and is going free. So as the patient breathes in, they're having decreases in pressure, which is sucking it in. And then as they exhale, it's pushing that section of the chest wall out because it no longer has the ribs there to support it, and it is pulling itself in as the pressure changes. It causes that unstable chest wall and paradoxical movement while breathing. The flail segment moves opposite. Inspiration sucks in, expiration bulges out. Here in figure 27.5, we just have another demonstration of how that flail chest works. A pneumothorax. This is caused by air entering that pleural cavity outside of the lungs. And that impairs, again, that positive pressure in the pleural space, causing the lung to partially or fully collapse. Increased air in the pleural space equals reduced lung volume. You should be suspecting a pneumothorax with any chest wall trauma. Here's just another picture of that pneumothorax and how the air is entering inside of that pleural cavity and not allowing the pressure changes the lung needs to inflate. Another major danger, especially in teenagers that are active athletes, is a tension pneumothorax. And this is an accumulation of air in the pleural space that cannot escape as a result of increased intrapleural pressure. It causes a mediastinal shift and hemodynamic instability, a reduced venous return, and reduced cardiac output. It can occur with an open or closed pneumothorax. In this case, we're going to be treating this with a chest tube, and we'll have some pictures of the chest tube coming up here as well. Hopefully you've seen these at your clinical site as well, get a little bit of experience. Just another figure demonstrating that tension pneumothorax and how the air is inside of the pleural cavity but outside of the lungs. Other complications could be a hemothorax, and this is blood within that pleural space that again is removed with a chest tube. You could also have a combination hemopneumothorax or a cryothorax, which is lymphatic fluid within that pleural space. Here we have that diagram. On the right is a chest tube. And what this is designed to do is to, as the patient breathes, extract the excess blood, fluid, or air from that pleural space to allow the lungs to expand all the way. It may be placed in the ED, the OR, or even at the bedside. It has a standard insertion site being mid-axillary, with the head of the bed going to always be elevated 30 to 60 degrees with an arm raised above the head. You're going to antiseptically cleanse that spot and place a small incision over the ribs so the chest tube catheter can be inserted. A suture would be placed to keep that steady and connect that pleural drainage system. So going to have prescribed suction on there, meaning you're going to get a prescription of how much suction should be placed onto that so that it's pulling out that excess fluid, air, what have you. Here on figure 27.8, we are just showing that diagram of how the chest tube would be inserted within the pleural space. And here's just another photo showing you various components of a chest tube, including the water seal, that suction chamber, how you could monitor for air leaks, and the collection chamber itself. And a little tip for that is have a Sharpie. As soon as you come on shift, put a mark of exactly where that started at. That way you know throughout, you can actually have just a good visual guide of how much fluid has collected throughout your shift. Here's another of that chest tube drainage unit. Again, it has 3 chambers. This one's going to be a little different. It's got the suction dial there where you could actually set the suction on the machine, though I'd also set the exact same prescription as on the wall, just so you got a good fail-safe. You don't want one of those to fail. I'm sure they're fine. I just never really trusted the suction on those. And let's talk chest surgeries. First would be a thoracotomy. This is a surgical incision into the chest. It could be median sternotomy, which is the heart, or a lateral thoracotomy, which is the lungs. Also got the latest and greatest, such as video-assisted thoracic surgeries, or VATS. It's a minimally invasive surgery involving 2D video imaging of the inside of the chest cavity, providing diagnosis and treatment of the pleura, pulmonary masses, and nodules. Next would be a thoracentesis, and this is aspiration of that intrapleural fluid for diagnosis and treatment. Find out exactly what is filling that pleural space. For larger volumes can result in hypotension, hypoxemia, and re-expansion of pulmonary edema. It could also be identified with chest x-rays. In this case, we're going to monitor the vital signs, pulse ox, and the patient for respiratory distress. Restrictive respiratory disorders. Next would be atelectasis. This is that collapsed airless alveoli, resulting in decreased or absent breath sounds, dullness on percussion, and caused by secretions obstructing the small airways. At greatest risk are going to be bedridden and post-op abdominal and chest surgical patients. And for prevention is going to be deep breathing exercises, incentive spirometry, and early mobilization. Always a fun word to say, but not as fun to have, is pleurisy. This is inflammation of the pleura, caused from infections, cancers, autoimmune disorders, chest traumas, GI disease, and even some medications. And it manifests as a sharp pain that's worse with inspiration. Could result in the patient breathing shallower and even a pleural friction rub at peak inspiration. And we're going to want to treat that underlying cause along with careful pain management. Next would be pleural effusion. And this is an abnormal amount of fluid within the pleural space that's a sign of disease. It's caused by increased pulmonary capillary pressure, decreased oncotic pressure, increased pleural membrane permeability, or lymph flow obstruction. It could have different types, such as transudative or non-inflammatory disease, or exudative, which is due to an inflammatory process. You also may see empyema present, which is pleural fluid within that pleural space. Interstitial lung diseases. Sarcoidosis. This is a chronic disease that primarily affects the lungs, resulting in dyspnea, cough, and chest pain. It may also affect the skin, eyes, liver, kidney, heart, or lymph nodes. The treatment is to suppress the inflammation and follow for 3 to 6 months with chest x-rays and CT scans to closely monitor that progression. And vascular lung disorders. First up is pulmonary edema. This is abnormal accumulation of fluid within the alveoli and interstitial spaces. It has a complication of heart and lung diseases. Most common cause is left-sided heart failure and results in pink frothy sputum. Next would be a pulmonary embolism. This is a blockage of one or more pulmonary arteries by a thrombus, fat, or air embolus. The clot within the venous system into the pulmonary circulations then lodges in the small blood vessels and obstructs that alveolar perfusion, meaning no gas exchange is taking place. And it most often affects the lower lobes. Here's a picture of a PE. This is a large embolus from the femoral vein lying within the left main and right pulmonary arteries. There's many different forms of thromboses that could travel and become a pulmonary embolism. There could be that venous thromboembolism or a DVTs. This is a clot that originates within the deep veins of the legs, the femoral or iliac veins, or the right side of the heart in the case of AFib. And other sources could be a central venous catheter or arterial lines. There could also be a saddle embolus. This is a large thrombus at the arterial bifurcation. Complications of a pulmonary infarction are occlusion of medium or large-sized vessels, inadequate collateral blood flow, and pre-existing lung disease, which results in alveolar necrosis and hemorrhage that may cause an abscess or even pleural effusion. Also, pulmonary hypertension may be a result. This results from hypoxemia associated with a mass of greater than 50% or recurrent emboli, and could also result in right ventricular hypertrophy. And finally, we've got a good wrap-up slide for this week. That's the prevent aspiration. Remember, for pneumonia, the priority is going to be vaccines for those 65 and older. We always want to prevent wherever possible. In the case of asthma, our rescue med is albuterol. And avoid triggers such as dander, dust, and perfumes. In the case of tuberculosis, airborne precautions. A sputum culture is a definitive test. Make sure you're really good on what counts as a positive result on those Manitou tests. So, because it's not all the same for everybody. For the general population is 15 millimeters, 10 millimeters for RNs in patients in prisons, patients in nursing homes. Anyone that is deemed in a higher risk population is going to be 10 millimeters and 5 millimeters for the immunocompromised. And I can't stress enough, as soon as you see isoniazid, really be prepared for a question about liver failure or preventing liver failure, because it is a severely hepatotoxic drug. But anyway, that's all we got for this chapter. I'll see you in the next slides.